स्पीकर को ही म्यूट करके हेलो, शिव सर स्पीकर है, शिव सिंह करके, उनको भी सबको म्यूट किया है, तो शेयर स्क्रीनिंग भी करा दो। बट उन हाँ,
I can do it,
okay,
Kala, it's fine.
Yeah.
Hello, so good evening, sir. Sir, shall we?
I think it goes in mute all the time, I think, because I think it's the setting is like that.
No, sir, it's on your side.
Yeah, but it, yeah.
Okay. Shall we begin, sir?
Yeah, you can.
Yeah, I'll hand over to my president, branch president, Dr. Smita Shah. Shah, madam. Madam. Madam, you're not audible.
Hello.
Yeah.
Warm welcome to all registered delegates on behalf of ISC Kalyan. After a successful journal club meeting, today we are moving towards our first CME on low flow anesthesia. Anesthesia technique has evolved from open drop ether to open circuits, semi-closed and closed circuits, and now with workstations with a very accurate, potent inhaler vaporizers. But still we know that these anesthetic gases are very costly and they are greenhouse gases and they contribute to global warming. So to make it more economical and more eco-friendly, this low flow anesthesia has evolved. But we still have a fear in our mind that can we apply this low flow anesthesia in our setups? So to elaborate more on this and enlighten on this, we have invited today most eminent speaker, Dr. Shiv Kumar Singh. And today, our young, talented, very dynamic treasurer of ISA Kalyan, Dr. Mahiresh Patil, is going to moderate on this session. So, Dr. Mahiresh, we are expecting much more lead for academic events in futures. Now, I request Dr. Mahiresh to take over. Dr. Mahiresh.
Hello.
Yeah.
I'm audible?
Yes.
Yeah. Hello. Good evening, all of you. Myself, Dr. Mahiresh Patil, on behalf of ISA Kalyan, welcome you all on today's CME on a very interesting topic, which is also topic very much useful in our day-to-day practice, low flow anesthesia. And today's topic, we have got a very excellent speaker, Dr. Shiv Kumar Singh, sir. Sir needs no introduction as such. He is very well known to every one of us, and he is very well known international faculty, excellent tutor and mentor. I have personally met one sir in task group conference and found that he is very much helpful and approachable. So I will just share a little bit about sir. Sir is consultant anesthesiologist at University Hospital Liverpool, and he is chairman theaters anesthesia, and he have keen interest in regional anesthesia, trauma and vascular anesthesia, and education and training. We have attended many lectures of sir, and he is very much into the academics. For today's topic, we will have a lot of knowledge regarding this low flow anesthesia. If you have to tell about sir, there are a lot of information. So he is basically MBBS MD from India, AIMS, and he is consultant anesthesiologist at Royal University now, practicing over there. He have lot many previous designations, and he is having many leadership and training programs, also many guest lectures, basically maximum lectures on regional anesthesia blocks, and also difficult airway, and also he is a faculty organizer in ultrasound guided regional anesthesia workshop for trainees, and we are very keen to hear from sir about this topic, low flow anesthesia. In between, I am a moderator, so in between, if there are any doubts, I will share with sir, and sir will help us. I simply hand over to sir. There are a lot many things to tell about sir, but the topic will not be get covered. So I will hand it over to the sir. Welcome you, sir.
Thank you, Miraj.
Yes, sir.
Mayurish, stop screen.
Should I start staying mine? You can. So, okay, so I will share my screen. So greetings from Liverpool. And this is where I live. These are statues, metal statues, hundreds of them in the sea. They call Anthony Bromley's Another Place. And on the right side, you actually see it's called the Liver Building. And it's there's a bird on the top of the building. And the Liverpool city is named after this mythical bird. So there are actually mythical creatures in UK as well. India has got lots of mythology, but the UK too actually has got some. And congratulations, first of all, to Kalyan and her team for the Indian Society of Anesthesiologists, City Branch, Kalyan and ISA for inviting me to this lecture. So I'll be talking about anesthesia workstation and low flow anesthesia. And I have tried to simplify it because if you actually read about low flow anesthesia or think about workstations, they're too complicated for people. And that's what I think they, when somebody says, can you tell me something about workstation? They go, oh, I don't know. It's such a complex machine. Or you talk about low flow anesthesia and say, oh, there are lots of equations. Those all equations and things I'm going to take away from that. So I'm going to simplify it and make it a lot more understandable for people who don't use low flow anesthesia or who do not understand it. I'll try to make it simpler. So before we actually go into the low flow anesthesia, I'll talk about the workstations a little bit. So what is the difference between an anesthesia machine and a workstation? Okay, I actually see people posting machines, some old machines. Some time back, there was someone who actually showed some machine which was actually fully rusted. I mean, these are basically museum pieces, but I mean, they have very important, historical value, knowing how everything has evolved because if you look at the basic anesthesia machine, the things are very similar, and I will let you go through that. The machines have evolved over a period of time. They've become a lot more complex. The web prizes, ether bottle, you can see ether bottle has been replaced by, tech web prizes. And we have different breathing systems. One of the things obviously for low flow anesthesia is having a, circle system. So which has got soda lime as part of the component. I have taken lectures on basic anesthesia machines. If somebody wants to go through them, they can actually go through that on the group or on my YouTube channel. So slowly and slowly, the machines actually started becoming a lot more complex, more electronic. There was more of computers added to the machines. So from being as totally pneumatically driven machines, they became a lot more complex. So that's the anesthesia workstation, and you can see that it's got monitors. There is actually a system for automated anesthesia chart recording what you're giving. So lots of things within the, so looks a lot more complex than a simple boil machine. And there are different workstations. People ask, okay, which is the best workstation? There isn't actually a best. Everyone is going to say. So you go to the Mindrega, you say, oh, mine is the cheapest and the best workstation. You go to Draeger, say there's nothing like Draeger. You go to G, they say they are the best. Okay, there are just subtle differences between those workstations. Okay. So basically, anesthesia machine is the main component of any workstation. So you have gas delivery system. There'd be mainly in big hospitals, they will likely have pipeline, but also there are cylinders at the back of the machine. Then they go through the flow meters, then from flow meter to vaporizers, and then to the breathing system. There might be a scavenging system, which should be very, very important. And there would be an interface with ventilator as well. So that's the basic anesthesia machine. So if you look at that schematically, you have a source. So source of your gases, whether that's nitrous oxide, oxygen, air, that could be from pipeline or cylinders. And then it goes to flow meter, vaporizer, breathing system, and then there's a breathing circuit to the patient, and then the scavenging part of it. So what is anesthesia workstation? It's basically your anesthesia unit, which had got everything which I've described, plus the advanced ventilation system. Okay, so they all got ventilators. Some of the ventilators are actually as good as ITU ventilators. So they give you can have SIMV mode, pressure control mode, ASB with PEEP and everything. You can actually do exactly what you can do in intensive care with the ventilators. So pretty sophisticated ventilators. Then there is anesthesia and patient monitoring system. So just not a multi-para monitor. So monitoring your heart rate, your blood pressure, ECG, IBP, anything you can actually monitor with them. But at the same time, also monitoring the anesthesia gases. You're delivering oxygen, the volatile anesthetic, carbon dioxide, nitrous oxide. And then you can actually have integrated with the electronic medical records. Okay, so in some centers, they will have that. We still actually don't use. This is one of my old anesthesia machines, and you can actually see there is monitors, but still a pen and paper there. So we still have that. That does actually get scanned and put into electronic record keeping, but we don't actually use electronic record within the theaters. Maybe in the future we will when we go paperless. This is a little bit more modern machine. This is my hybrid theater where I work for vascular. So you can actually see there are a lot more things. This is just before we actually get the patient in. So in UK, we actually have anesthesia rooms. And in the anesthesia room, do most of the anesthesia part in the anesthesia room and then bring the patient into the theater. So why are we actually talking about workstations? Why are they essential part? Okay. So this is just in May 2021, just this year, a few months ago. The AGBI again came up with recommendation for standard of monitoring during anesthesia and recovery. And it talks about, there's lots of things in it, but I'm just talking about the monitoring devices. They say in all cases, we should have pulse oximetry with plethysmography. So we just not the numbers, but also the trace. We should be able to measure the blood pressure automatically using non-invasive blood pressure, ECG, of course. And temperature monitoring is also a must and should be monitored, continuously for long cases, but in case you can also monitor every 30 minutes till the end of the surgery. And during general anesthesia, you need to monitor the inspired and expired oxygen concentration. You need to monitor CO2 using capnography. And then again, depending on whether you're using a TIVA or you're using volatile anesthetic technique, you need to monitor the inspired nitrous oxide, inspired and end-tidal inhaled anesthetic, the agents, the volatile anesthetic agents. Then within the ventilators, there will also be airway pressure monitoring, tidal volume monitoring, respiratory rate, and some of them will also have the loop systems, which are very useful, especially when you're doing low flow anesthesia. And if you're using TIVA, then you need to actually be using something like a BIS monitor, which is a processed EEG monitoring. And if the patient diabetic also. So there are lots of things within the monitoring, and this is very, very important part of it. And coming to, if you are actually using volatile anesthetic agents, then you need to actually monitor the end-tidal anesthetic concentration. And most importantly, the MAC monitoring is important, and it need to be, if you look at it, it says we need to maintain the end-tidal anesthetic concentration of more than 0.7, that is MAC of more than 0.7. And it should be age adjusted. Okay, that's very, very important. Actually, a lot of the old monitors don't actually have that. So it need to be age adjusted MAC. So that's important part of that. So newer workstations have got all this, and that's why having a workstation is important. So you can actually have a simple machine, but if you actually have a monitoring system for all this, you can still use them because it allows you to actually know what has been delivered at the end of the machine, what is coming out of the the machine end. So that's important. But with the new workstations, everything is integrated, so it's easier that way. So coming to low flow anesthesia. Okay, so like I said, I was not going to go into details of the machine or what is there. You don't need to know because the machines will actually have electronic flow meters, and I can actually talk about. There's a whole session you can actually do on that. You can do on web prices. But like I said, it's a basic thing. You have the source, and then it goes through, it's pressure reduction valves are there, and goes through the flow meters, then to the vaporizer, then from vaporizers to come to the breathing circuit, and then breathing circuit, different types. Obviously, we'll be talking about more about the circle system. So the actual topic, today's topic, is about low flow anesthesia. People get scared about it, okay. But it's not as scary because that's because people start talking about minimal flow and metabolic flow. Okay, we don't actually have to be that stringent. You don't actually have to go to metabolic flow or minimal flows. Even if you're able to actually maintain actual low flow anesthesia, which is around 0.5 to 1 liter per minute, that is good enough. In our setup, we tend to actually not allow the trainees, and that is the low flow society's guidelines, that the trainee should not be using flows less than 1 liter. As a consultant, you can go up to metabolic flows. It's up to you. But you need to have, you be very vigilant, and your monitoring has to be very stringent. So low flows, 0.5 to 1 liter, medium flows, 1 to 2 liters. Some people still use that. But less and less people are using high and very high flows. So I think if anybody is using that, they're just wasting gases. Okay. So the main requirement for low flow anesthesia, and that's where the workstation comes in, that you need to actually have a circle rebreathing system. What it means is basically, because it's got a soda lime which can absorb CO2, you can actually return back the gases into the brain. So it's a rebreathing system. And you need flow meters which are accurate, so you're able to actually adjust gas flows less than 1 liter. If you see the flow meters, where there are 2 flow meters for, say, oxygen has got 2 flow meters, you see that up to 1 liter. And then 1 liter is actually then divided into 100 ml. So those kind of flow meters are important. Our machines, newer machines, actually have electronic flow meters. You just need to set the flows. And the FIO2, it's automatically will actually set the flows for oxygen air or oxygen nitrous oxide. I will show you in a video in a minute. It's all equally important that it's a tight breathing system. There are no leaks, or the test leak is less than 150 ml per minute at a pressure of 30 centimeters of water. And then again, the testing is no longer done manually. It's all done automatically in the machines. In the newer Workstation, like I said, they are computerized. So all they need to do is actually let me alone, and it'll go through one by one through everything. And wherever there is a problem, it will actually highlight that. Okay. And obviously, you need to have continuous gas monitoring, okay, able to monitor oxygen, nitrous oxide, your volatile anesthetic agents, and be able to also set in the age, so you can have age-adjusted MAC monitoring with them. So this is actually from Miller, and you can see this is a circle system, and showing the inspirative phase where the gases are actually coming from the fresh gas flows. And there are actually gases which would have collected in the reservoir bag that's been ventilated, or it could be a ventilator, and then flows to the patient. There are one-way valves, inspirating, expirative valves. There is, in the inspirative side, there is an oxygen cell, oxygen fuel cell, which measures the oxygen concentration. It can be part of them within the machine as well. So some Traeger machines are within, others will actually have, you have the fuel cell on the top of the one-way valve. And the expirative phase, obviously the inspirative valve closes on that side, the expirative valve opens, gases flow through, and the fresh gases go through your soda lime, which is in the center, and then they collect in the back. So and the circle, that's how it keeps going. This whole cycle keeps going on, and there's obviously APL valve as well, where the excess gases are vented out. You can actually see on the very right end from where it is also attached to the scavenger as well. So this is the video I was talking about. Okay, you can actually see these electronic flow meters in them. I'll show a close-up. So we're using here, that is age is actually registered. So it's an age-adjusted MAC of 1. This is probably beginning of the case, because you normally go down to almost 0.5 to 0.7 to 0.8 MAC. Two-way prices on there. We're using sevoflurane here. And then we're using a circle system. This is a bag is well filled. So these are appropriate amount of gases, not collapsing. So if it is collapsing, then you know that you're not actually providing enough gases. No, the one also got an econometer. So you can actually see that it is actually on green, so it's efficient. And we're using 70% oxygen air. As I reduce the flows, you can actually see as it goes to 25, the FID reduces to, and 200 mLs, the FID goes to 100. So that is when you actually are nearing or less than the metabolic rate. It cannot give you any mixture. It will have to deliver only oxygen, because that's what it requires. The oxygen consumption for an adult is around 3 to 5 ml per kg body weight. Also, on average, around 250 ml is consumed. So you cannot actually go down below 250 ml for metabolic requirements. So that's the machine. You can see the MAC monitors, flows, electronic flow meters. You don't actually have to adjust the flow rates. But again, I'll show you in other ones where you can do that. So obviously there are certain advantages and disadvantages of requiring that. And first is the direct cost. So if you actually want to conduct cases under GA with low flows, and then you need to actually have a proper workstation, proper monitoring system. So that is the actual direct cost. It's there. And once that cost is taken into account, then you can actually start about how you're going to have your savings, okay, over the period of time. So somebody who is actually using flows of 5 liters per minute, almost 80% of the gases are going to get wasted. These are going to go into the environment. Okay, there is question about depletion of ozone. And if you're not using the scavenging system, you would be breathing these gases in. You go home, you feel sleepy, you feel tired. Okay. So those things are, obviously, and that is because you're wasting gases, it's going to cost you a lot more. So if you actually look at the fresh gas flows, and even if you were using 3 liters and reduce it to 1 liter per minute, that is almost 50% saving. So once you actually have the workstation, then using low flows makes sense. So we're not only saving the environment, we're not saving ourselves from inhaling those gases, but we're also saving, so we're reducing the cost of anesthesia as such. Obviously, you can't compare this with regional anesthesia, pure regional anesthesia, nothing like it. No question, that's the cheapest method, but assuming that patient requires a GA, then it's possible to cut the cost, okay. And this is actually a graph which is showing that with the newer agents, I mean, people still use isoflurane, some places still use halothane, but if you look at the commonest gas used nowadays is sevoflurane. It's very pleasant. You can use it for the gas induction, easy to handle. So if you look at sevoflurane, desflurane at high flows, look at the cost difference is actually huge. So when you reduce the flows from 5 liters to 1 liter, the cost goes down by almost 30%. More than 70%. So yes, cost savings with that. So how do we practically approach the low flow anesthesia? Okay, what are the components? Like I said, people who talk about all kind of equations. Okay, you need to have this equation, that equation. Now you have to go back. Do I really need to know those equations? Those equations were actually used in the time when we didn't actually have sophisticated machines, and people still wanted to use low flow anesthesia. So they wanted to, be accurate in their calculations. How much is going to the patient, how much is coming out. Are we going to make them hypoxic if we continue with these flows? Okay. Those kind of questions, those were important. But now the machines where we have machines where it is monitoring what's going in, what's coming out, you don't actually need all that kind of calculation. So it's all just more theoretical, important for confusing people or impressing people. You say, I know this equation, I can explain it. You don't need to actually have all that. So we'll go to a very practical approach of that. Okay. So the first phase is that you are going to actually do anesthesia as you would actually normally do in a theater. Okay. So let me take you to what I do in my cases. Okay. So patient comes in, they have his checks in, we connect them to monitor ECG, blood pressure, SpO2, get a drip in. I don't actually use denaturation or pre-oxygenation, as people call it. If the patient's saturation is 97 to 98%, I just leave them sitting up a little bit. Okay, breathing on, fill their lungs up with air, and induce them with propofol. Okay, that's all you use. Get my eye gel in, leave them breathing spontaneously. Okay. So in the anesthesia room, when they start off, I'm going to actually leave them around 6 liters flow. So I'll leave them around 6 liter flow, and with the usual concentration. So if I'm using sevoflurane, I'll leave them on 2 to 3%. Okay, we're still monitoring the concentration, what's been delivered to the patient. And once everything actually settles down, you need around 15 minutes or so. Okay, so at this time, we do rest of things. We do the blocks, or the surgeon comes and they will likely do the checks or preparation of the patient. So you get enough time for equilibration to occur. Okay. So for the fresh gas flow, we will actually require initial high flows. Okay, and then we move on to the low flow. So once we have actually got a stability, okay, we have reached the MAC for that patient, and then you don't actually change the setting on the vaporizer. Okay, you do one thing at a time. So you reduce the flows. Okay, leave them for step, just be equilibration. Okay, and then after that, you can actually start reducing your the dial setting on the your vaporizer. Okay, so never do 2 things at a time. Just do one thing at a time. Okay, and I'll come to that again. I'll talk about why that is actually important. Okay. So we adjust the fresh gas flow in 3 stages. And last thing is the recovery. In the recovery phase, we tend to switch off the volatile anesthetic, increase the flows, and let the patient wash out. So it's just opposite of what do we do at the induction time. So induction, we are washing in the anesthetic gases, and at the time of the your recovery, you're washing out. So letting the body, at least the patient is breathing, they will wash out the anesthetic gases. And once they reach the MAC awake, which is usually 1/3 of the usual MAC, and they will start actually getting back their reflexes and waking up. So why initial high flows are actually required? So say, for example, you are actually delivering 100% from the machine, but the lungs itself, okay, if you look at, we have the total lung capacity is around 6 liters. And of that 500 tidal volume, okay, the rest of this is your water capacity. Okay. Lots of it functional residual capacity of around 2.5 liters on average. So it varies from 2.2 to 3.3 liters, depending on male or female and size of the patient. This is filled up with 21% oxygen and 78% nitrogen. So our aim is to actually, get 100% oxygen in, fill the functional residual capacity or the inspirator capacity, which is there with the oxygen, and get rid of the 78% of nitrogen. So that is what denitrogenation is. So how long does this going to take? Is there a scientific way of knowing that? And the answer is yes. Okay. And there where the equations come in, but these are actually simplified equations. Okay. We're just showing that how the especially the oxygen or nitrogen or volatile anesthetic, it have to actually, depending on what volatile anesthetic you're actually using, how the the concentration buildup or washing actually happens. So it's very quick for ones which are less fat solubles like desflurane, sevoflurane, but it's going to be slow for something like halothane or isoflurane, which actually goes and get deposited in the fat. So knowing about how much time we require, we need to actually get to know about the time constants. Okay, so there are two things: the rate constant and the time constants. A rate constant is basically your rate of flow, and flow is just volume over time, which is a liter per minute over volume. And the time constant is just opposite of the rate constant. So the tau or the time constant is volume over rate of flow. So if you can look at the rate constant, the unit is going to be 1 by minute, whereas the time constant is going to be minute. Okay, it's opposite of the rate constant. Okay, so how are they different? So I'll give you an example. Okay, so say for example, you have a bathtub and you want to fill it, and the flow rate. Say the flow in the this is a say like 100 liter of the tub volume. You want to fill it up to 100 liters, and the flow is 1 liter per minute. So from that you can calculate how long it is going to take for the tub to fill up. Simple, that's the rate constant. But say that your child has actually come from playing football. It was raining, full of mud. It gets into the bath, and there's mud in the bath. Okay. And now you want to clear this mud, right? So if you actually fill the tub with just water, it will actually get muddy. So you want to actually clear this mud. How long is it going to take for this mud to clear off? Okay, at the same rate. So assuming that the the drainage is actually the same as what is water coming in. So if 100 ml is coming in, 100 ml gets out, say for the example that way. Okay, so then the rate is say 100 ml per minute, and the wash is also 100 ml per minute. In that case, how long is it going to take? That is what is about time constant. So you can look at it, for example, that in the lungs, we have nitrogen. Okay, say for example, that is the mud. Okay, and oxygen is the clear water. So how long will it take for us to get rid of this nitrogen? That is the time constant we're talking about. Okay. So like that, like I said, time constant is volume over rate of flow volume over rate of flow, and rate of flow is volume over time. So if you cancel out the volumes, all you left is 1 by time. That is equal to time, because time moves up. Okay, so the unit for time constant is going to be minutes. Okay. So for simplification, let's say our minute ventilation is 4 liters per minute. I assume they are PG students, so just said minute ventilation is nothing but tidal volume into the respiratory rate. And like the functional residual capacity can vary between 2.5 to 3.3 liters, but for ease of calculation, let's say the functional residual capacity is 2 liters. So in this case, the time constant is going to be 2 liters or 4. So that's going to go into 0.5 minutes. Okay. So how is this important? Okay, so if you look at the time constants, so one time constant, you have completed around 63% of the process. By 4 time constant, it is around 98%. Okay, so you need around 5 to 6 time constant to complete a process. So like we were talking about the mud in the bathtub. Okay, so if you actually calculate the time constant for the clearance of mud, then you would need whatever time constant you get, you multiply by, say, approximately 6. Okay, but if you actually allow that time, then you will actually have clear water in that. So that's what time constant is. Okay, so that's, you need to know that by 4 time constant, 98% of the process is complete. So for the lungs, that's the rate constant. So how much oxygen is going constantly, that may be rate constant. When you're talking about time constant, then we're looking at how the oxygen is replacing the nitrogen when you give 100% oxygen. Okay, that's like knowing the time constant. So washout of nitrogen or washing of 100% oxygen, it will take, say, 0.5 into 6, that is 3 minutes. Okay. This we are assuming that the circuit is already primed with 100% oxygen, and I'll come to what that priming means. So on the right side, you can actually see a graph that by the 4 time constants, the oxygen is almost like replaced. 98% of the nitrogen in the functional residual capacity has been replaced with the oxygen. So you got good reserve of oxygen, and that's good enough actually in most of the times. So what is not nitrogen is oxygen. That's what I meant. So when you're actually replacing that, so washing of the nitrogen is equivalent to washing of oxygen. Okay, you are just replacing nitrogen with oxygen. And that's why the process is not called pre-oxygenation. It is called denitrogenation. So that's very important concept to tell. Okay. So we also know that, say, for example, is a first case of the day. Okay, the machine has been shut off during the week. In the first case of the day, it's not been primed. And how long will it take for us to fill the whole system with 100% oxygen? Okay, that's what its priming is. Some machine will actually have a basal flow of 200 mL. Even if you actually get the flow meters down to 0, they will keep giving you 200 mL of oxygen constantly. Okay. So circuit volume, including the the circle system, the CO2 absorber, can be approximately almost 6 liters. So it's almost equivalent to what your vital capacity is. Okay, so 6 liters is the circle volume. So if we now actually have the flow, we set the flow of oxygen to 6 liters per minute, and the time constant is 1. And like I said, so it takes 6 time constants to complete the whole denitrogenation, or so filling up or washing out. Because what is going to be left in the circuit once the machine is switched off is just air, okay, which is oxygen and nitrogen. So it takes around 6 minutes. But say, for example, you use a flush. Now the flush on the oxygen actually deliver anywhere from 50 liters to 70 liters per minute. And let's say, for ease of thing, that is delivering 30 liters per minute. So if you actually use a flush, and the time constant comes down to 0.2. So 6 liters or 30 liters per minute, and that's 0.2 minutes. And 6 time constant is, okay, that is 6 into 0.2, 1.2 minutes. So if you actually keep the flush on for 1.2 minutes, so almost a minute or so, you can actually, wash out everything, and you can prime the whole circuit. So it depends on what flows you're using or when you start using the flow. So that's important concept in low flow anesthesia. Okay. And like I said, some machines have basal flow of 200 mL of oxygen going all the time. In those cases, if you look at it, so you have 6 liters or 0.2 liters per minute, that's 30 minutes. And 30 into 6, 180 minutes. So you need 3 hours. So once you switch on the machine, so when you come back, and if you leave the machine for 3 hours at 200 mL, it will take us 3 hours to prime the whole system with oxygen. Okay. So that's a long time. So we would like leave it for, give a flush, 30 liters flush for 1 minute, and it is all primed up. Okay. So what about the volatile anesthetics? Okay. So volatile anesthetics are actually carried by your carrier gases. So oxygen air or oxygen nitrous oxide, these are all carrier gases. Okay. Volatile anesthetic travels along with it. It's a carrier. It's like the child on the dad's lap. Okay. And hence, it's important because they're carried. The rate of change of the volatile anesthetic will actually depend on the rate of change of the the carrier. So if you walk slowly, the distance travel is the same as what the dad and mom are actually going at the speed. Okay, so if they travel fast, they will actually reach quicker. Okay, same thing actually holds with volatile anesthetics as well. So when you have low flows, and say your MAC drops to say 0.5. Now, if you just increase the concentration from say 2% on the sevoflurane to 7%, it's going to take a long time because the carriers are actually going at the same rate. Or the best way is, okay, leave it at 2 or 3% and increase the flow. Okay, so increase the speed of mother and father. Okay, and then you reach quicker. Okay? So that's very, very important. And that's why it's important to actually set your alarms on the machines. Okay, so you don't want the MAC going up. Okay, you don't want patient waking up, and that's one of the flows. Okay. So low flow anesthesia, nothing but utilizing the waste. Okay, we are actually helping the future generation. We are helping to save the earth, and that's why low flow anesthesia is actually important. So how do we do it? So I have actually already, talked about one of the main concepts in the low flow anesthesia. Now I'll take you through the rest of it as well. So this is a nice diagram where we're showing that we are using oxygen nitrous oxide, we're using sevoflurane, and we use giving 1.25% of sevoflurane with 50-50 almost of oxygen nitrous oxide. So what we take into the body, okay, what is used up by the body is very small amount, because if you look at what has been exhaled, so out of the 1.25%, 1% is being exhaled out of the sevoflurane, which will go into the atmosphere. Okay, almost 42% of the oxygen is also wasted. Okay, not a big thing, but what about nitrous oxide? 45% of the nitrous oxide. So the idea of the low flow anesthesia is to actually, use that and return it back to the inhalation, so that we can reduce the amount of the fresh gas flows. So we just need to recycle it. So it's all about recycling the gases, in a clever way. Okay. So it's as simple as that. Okay. So we're recycling it. And for doing this recycling, we need to actually have monitoring is the most important aspect of it. Okay. So now we know we need to recycle, but what do we need for that? Obviously, this stuff, isn't it? That's what I was actually telling you about. We need to actually have a workstation. That's where it comes from. The monitoring the gases, being able to actually use this MAC, able to know how much is going in and how much is coming out. Okay, that is very, very important. Okay. So recombinant low flow anesthesia, this is again a repetition of the previous slides I've shown before. So we need a circle rebreathing system with soda lime, obviously. We need to actually have flow meters, which can be adjusted to fresh gas flows of less than 1 liter per minute, no leaks within the system, and continuous gas monitoring. This is very, very important. Okay. So let's start off again, how we actually conduct it. Okay. So initial 15 minutes, 5 to 15 minutes, you need to actually have initial high flows. And I've already explained to you why you need to actually have high flows at the beginning of the case. Especially if it is the first case of the day, do not forget about priming the circuit. Okay. Use your flush or use high flows Okay, remember the time constant required, okay, for the circuit. So that's going to be constant from most breathing systems, so you can't go wrong in that. Then about the patient, we might require to, obviously it's not only denitrogenation of the patient, it's also denitrogenation. What we did by high flows, initial high flows, you denitrogenated the whole breathing system. Okay, there was nitrogen, plenty of nitrogen in the air. Then we need to actually rapidly wash in the desired oxygen concentration. So we need to build up the oxygen air or oxygen nitrous oxide and your volatile anesthetic concentration to be able to actually get to up to a MAC of almost 1. So we start off with 1 and then we actually start reducing it. You don't have to go above 1. Okay. But we also need to actually avoid the gas volume deficiency. And this is very important to understand. What is gas volume deficiency? Okay. Then once you kept the patient on high flows, you managed to actually get the MAC up. Okay, patient is actually nice and well settled. So when do you go on to the low flows? Obviously, you can actually decide after 5 to 15 minutes, you reach equilibration. Okay. At low flows, you have to remember that what you set on the vaporizer concentration will not match what has been delivered to the patient. Okay. There's always be discrepancy in that. Okay. It's always low. So when you're having low flows, even say for 1 MAC, you might actually need to deliver higher concentration. Keep the dial at around 2 to 3% initially. Okay. Later on, you can reduce that. Okay. So the time required to reach the desired concentration can be prolonged because of the low flows. And it's very important to monitor the oxygen concentration because you can actually have hypoxic mixture being delivered if you're not careful. And the end-tidal anesthetic concentration or ETAC is actually essential to know, because last thing you want is have these MAC dropping down or patient waking up. So that's equally important. Okay. So this is a graph for looking at the various agents, and we can actually see that agents like isoflurane or sevoflurane, they also actually go into the fat. Okay, so they are fat soluble, higher fat solubility. Whereas desflurane, nitrous oxide, they are not fat soluble, so they equilibrate very, very quickly. So this is actually important to know how quickly you would reach the alveolar to the inspired concentration. So you need to reach the ratio to 1 as quickly as possible. And this can actually take time if you're using older anesthetic agents. Okay. So coming to what is gas volume deficiency. So if you actually reduce the flow, so you got a patient induced anesthesia, you got a patient onto the oxygen or nitrous oxide as volatile anesthetic agent, and you say, oh, got to reach the MAC, now I'm going to drop it quickly. Okay, that's when things can actually go wrong. So when the volume of the fresh gas falls below the total gas uptake, now you have to see that the uptake in the initial phase will actually, like I said, depend on what volatile anesthetic you're using. So if you're using isoflurane or sevoflurane, you need a little bit more time compared to desflurane. And if that gap occurs, that is when we say there is a gas volume deficiency. And when this happens, then it can trigger disconnection alarm. You say, why is the machine giving alarm? I'm fine, everything is connected fine. Or if you actually have rising bellows, okay, the bellows will not reach the top. Okay, so these are two of the things that can be noticed with that. So this is the alarm system is actually set at 10 bar, and on the left side, you can actually see the peak and plateau on the graph. And slowly this peak and plateau will actually go below the graph. And that's when the machine will think it has got disconnected, it is losing volume, or something has happened wrong, and then start alarming. So gas volume deficiency can cause disconnection alarm. And then if you look at the graph, the oxygen concentration can also fall, okay, because the too rapidly have reduced. There are different causes for this. But in most cases, it will never be exactly at the same what he actually set. So even if you set 50%, you will see that it will actually come down over the period of time. And there's very important cause for this. Okay, so one of the things which is important is that there is denitrogenation happening. So this happens especially if you are using higher concentration of oxygen. And we tend to produce nitrogen, constantly produce nitrogen. And if you're using low flow anesthesia, the soda lime, it cannot absorb it. It just actually get accumulated in the soda lime and it'll constantly dilute it. So the only way to do is to actually keep the FiO2 on the higher side, or in between you actually give a flush and wash out the nitrogen within or increase the flows. So you have to have a close eye and make sure that your alarms are set. I have seen the FiO2 going down to almost 18% when people were not actually, knowing what was going on. They said, oh, we set the FiO2 to 50%. So why is it actually 18%? That's because the nitrogen is accumulating throughout the system. Same thing happened with nitrous oxide. After some time, the amount of nitrous oxide equilibrates in the system. So whatever extra you're getting is just going into this circle and diluting the oxygen. So same thing, even if you whether you use oxygen air or use oxygen nitrous oxide, it is going to dilute it. So after some time, you can actually switch off the nitrous oxide completely. It'll keep circulating in the system. So this is just a very short video. Okay, you can actually see that. I've set it to 70 and 70. Okay, so that is my rule. So if you look at it, the oxygen is at 450 ml, air is 250 mLs. And I've seen that. So this is, I call it my rule of 0.7. So the FiO2 of 0.7 and flow of 0.7 liters total. I've seen that if you actually use this combination, then you can forget, that you will actually have hypoxic mixture at any time. This is for air. This is for air. So when you're using oxygen air, you keep it at that, leave it, forget it. Okay, you will never actually get to a hypoxic concentration. But if you do this with 30 to 50%, you're invariably, you can actually get to a hypoxic concentration within 2 hours. You will actually see there is accumulation of nitrous oxide diluting the oxygen to hypoxic levels. Okay. So coming to the recovery phase, like I said, once everything is done, it depends on the duration of surgery, obviously. It's absolutely opposite of what we did at induction. That's what we're going to do, isn't it? If you are given neuromuscular blockade, you will going to reverse it. Okay. And once the patient starts breathing off, you're going to switch off the volatile anesthetic. You increase the flows of oxygen. Okay, most people give 100%. I don't believe in that. We tend to actually give it to 70%. I'll keep the 70%. Nitrogen is important for the lungs. It's got a splinting effect. Okay, and depending on what agent you have used, if you use desflurane, sevoflurane, patient will open up their eyes very quickly within 5 to 10 minutes. They will once they're down to MAC awake, which is 1/3 of the MAC, and they start waking up. Okay, so nothing. There's no rocket science in this. There, like I said, there are potential risks with low flow anesthesia. I explained how accidental hypoxia can happen. Hypercapnia can happen as well in these patients, especially if you are, not taking care. You need to make sure that soda lime is fresh. Any amount of exhaustion there, CO2 can start. So you need to have functioning soda lime at all times. And because the volatile anesthetic concentration varies with low flows, and if you don't keep an eye on it, again, patients who are paralyzed, inadequate depth of anesthesia and awareness can happen. Now, because we're using soda lime with low flows, they are people who say, well, you get all compound A, compound B, those sort of things are not, they never reach the level. So if you're looking at the compound A with sevoflurane, you need to actually reach more than 50 parts per million to cause any kidney damage. And in clinical setting, that's never been seen. So this is very rare, but it can happen. But you can have accumulation of carbon dioxide. That is a very interesting bit especially with desflurane. It accumulates quite a lot in that, and it can actually start messing around with your monitoring. Your CO2 will start rising because it is detected as CO2 by the analyzers. Okay, so toxic metabolites. Less of a concern, but it can happen. When you take blood gases in long cases, you will actually see carbon monoxide levels rising. So just to summarize, if you need to actually practice low flow anesthesia, you need a workstation. You need to understand the concept of time constants. Okay, like I said, it's not anything rocket science. You can calculate it very easily. If you know what flows, you know the volumes, so you can actually get the time constants. And for any process, it's 5 to 6 time constant. The process is almost complete. And you require constant vigilance. I mean, we are actually used to that as anesthetists. That is our motto, to be vigilant at all times. But setting up alarm limits, okay, at the beginning of the case helps in that. So even if you're distracted or you are busy doing something else, like putting records in, yeah, alarms, when it alarms, you know that what's wrong. So that's important. And if you are practicing anesthesia and you do a lot of cases with general anesthesia, it's necessary to save the environment and save money. And that's what low flow anesthesia does. And so once you actually have invested in a good workstation, then you are going to save time. And low flow anesthesia, like I said, it's about recycling the useful waste. Okay, what we breathe out can be actually used. Okay. One thing I didn't touch upon is low flow anesthesia with endotracheal, with emergency breathing. If somebody has got their mic on, please, can we please ask them to switch off, please? Thank you. So, yes, you can use low flow anesthesia. I've been using it for years and years with athletes. Is the easiest way to do. So if you really want to learn low flow anesthesia, start with spontaneous ventilation. So if you have a good tight fitting mask, there's not much leak around it, and you don't use neuromuscular blockades with supraglottic devices. In most cases, you can actually use low flow anesthesia, easy to just, you just keep observing the back shouldn't collapse. You can put a APL valve to 5 to 10 centimeters of water, so there's less leaks around it. So it's very easy to actually do it with even with spontaneous ventilation. And even if your patients, the ETAC, that is the enteral anesthetic concentration, drops to a little less, they will start moving. They won't, they will give you that with the first indication that you are actually need to actually increase your flow. So it can be done with both endotracheal tube as well as with spontaneously breathing patients. Okay. And thank you for listening, and thank you for inviting me. I'll stop sharing screen and ready for questions and interaction.
Thank you.
Thank you, sir. Sir, I'd like to ask.
Yes, Preeti. Sir, we have few questions. Mayuresh, you can go.
Yeah, go ahead.
Sir. Yeah. There are some of the questions, like if there is disconnection in between, someone asked, and bellows fall down, then we have to again start up with the high flows, and then
Absolutely.
Yeah. Okay.
Absolutely. Anytime there is disconnection or because the moment you get disconnected, you actually lose a lot of you will likely, so go back, always go back to, it's always like go back to the beginning. Okay, start from there and then start. So never assume that there will be concentration. You will see with low flows, when there is a disconnection, the MAC actually drops very, very quickly. Okay, so that's one thing. Other thing I would always suggest, when you're using low flows, always keep a syringe or propofol with you.
Okay, fine. Yeah.
I would always give a small dose if that's happening, or your MAC has actually dropped.
Early age.
Just give a bit of propofol and then take over from there.
Yeah.
Even in spontaneous breathing patient, I would actually say is that always keep a propofol syringe with you.
Yes, right, sir. The same, the question related to the same. If there is the in between the case, we have to reach the depth of anesthesia earlier, rapidly. In that case, we can use IV anesthetics, like
Yes, that's
changing
what
the
we're doing, isn't it? The
concentration
induction
of
is
low
same.
flow.
Induction.
Yeah,
Induction is with propofol, so you
Yeah.
actually that's what you do. You
yeah,
obviously you can do gas induction.
Yeah.
There are times when patients,
Right.
they say that they can't have IV, so you will actually start off. Patients don't like IV, and then you start
Yeah,
gas induction, get IV line, and then do it. It happens.
Right.
But induction is always intravenous. Like I said, induction is not
Yes.
necessary.
No,
Okay, like
no,
it's
sir.
the same.
In
It's not
between, in between the case, if
can.
yeah, we can use the IV anesthetics
You
because
can, or
to
you
reach
need to
the
increase
rapid.
dose.
Okay, but
Yeah,
that
you need
will
to. So
that will take care early if we just increase the flows, or it will take time.
exactly, I've given you the answer at the beginning itself. If
Yeah.
your MAC is
IV
dropping, okay,
Yeah.
you need to increase the flow.
Yeah,
Okay,
and
it's
can
like I
use
said, remember the child, okay, being carried on the father. Okay,
right.
yeah. So it is, where are you going to reach? Okay, so it depends on how fast the father is going,
Correct.
right?
Yes.
Yeah. It's
So you
carrier, it's
said-
the carrier gas. The volatile anesthetic is carried by the carrier gases. Okay.
Yes.
If you need to increase the concentration, you need to increase the flow of the carrier gases.
Yes. So you said that low flow anesthesia affects CO2 absorber because the nitrogen also depletes the absorber. So there is more concentration of more absorber needed in low flow cases or something like that.
No. That's not. That is to do with nitrogen accumulation.
Yeah.
So we actually have nitrogen. So especially if you're using air, there is nitrogen in that. Body is producing nitrogen.
Right.
And that the soda lime doesn't absorb it, so it will get collected in the breathing system. That will dilute the oxygen. Okay.
Yeah. But it will
Otherwise,
not
the
affect
rate of absorption is the same, whether you're using high flows, rather it will be the high flows which will cause that. So rate of CO2, it's basically reacting with CO2. It's not reacting. You're producing CO2 at the same rate.
Right.
Whether you are actually using low flow, high flow, it does not matter. It's your CO2 production.
Yes.
Right. CO2 production is almost constant unless you go hypothermic or you develop malignant hypothermia when you produce more carbon dioxide, then it'll get exhausted. So irrespective of that, okay, CO2, the soda lime will likely just absorb your carbon dioxide. That's what it is meant for. Okay, maybe a bit of volatile, but most of the volatiles get recirculated as well.
So are there any changes seen in the capnograph in low flow compared to the someone said that there are lower concentration of EtCO2 are seen during the low flow?
No, that's absolutely wrong. That's absolutely wrong. Okay, the CO2 actually should not, rather you will actually see, especially in spontaneous breathing patient, you will see a CO2 rising.
Crazy.
But that's the thing. But low flows should not affect your capnography. Capnography depends on, again, it's to do with your CO2 production.
Right.
Okay, if you're actually having low CO2, either there's a leak somewhere, your CO2 is leaking out somewhere, or you have got hypotension where then your CO2 actually will be affected by it. Okay. So it's simple. It's your ventilation perfusion matching, isn't it?
Mm-hmm.
So if your perfusion goes down, your CO2, even your production is the same, that will go down as well. Or there is actually leakage at the point where, because you actually have system, there are almost 200 mLs are withdrawn. Again, I did not touch upon that again. So you got machines which do not return back the gases which are taken in for analysis.
Okay.
Right. So in those cases, 200 mLs is being lost constantly.
Okay.
So you can't actually have patients on 200 mLs. You can't, or 250 mLs for metabolic rate. So you need to add that.
Okay.
So that means it's better off just being around, 450 to 500 mLs of the. So if you want to also be minimal flows. So you need to actually know from your workstation whether the gases which are actually withdrawn by 150, 200 ml per minute, are they added back or they are actually vented out. That is equally important to know.
Okay. Yes, sir. Sanjot madam, I asked whether low flow anesthesia can be used in extremes of age, like neonate child.
I do not actually
obese
have
patient.
experience with the pediatrics. I did pediatric long back, but yes, there are actually pediatric circle systems are available, so you can actually use them. And yes, elderly, I use it. I've used in 100 years old. We use it all the time. I do a lot of elderly patients, so we use low flow anesthesia in them all the time. Low flow is for everyone. Circle system is for everyone. Circle system is a universal breathing circuit or breathing system. It can be used for pediatrics like that. There are actually smaller tubing with less amount of gas, so it can be used for that as well. But saying that, I don't actually do pediatrics. I mostly do adults. So we can always actually ask our pediatric in the pediatric symposium about that. They can talk about the low flows. But I think I'm sure they do use it.
So in obese patient, any problem happens with any
low flow. So in
specific-
obese patients, again, you have to be, because there are a lot of fat, and then if you're using agents like isoflurane or even sevoflurane,
volume
if
obese?
for short surgeries, it does not matter for short surgeries, but long surgeries, your wake up will be slow.
Okay.
So you need to either switch off the anesthetic gases early, the volatile anesthetic early,
And IVN.
or you use something like desflurane for them.
Mhm.
But I tend to actually use, even in morbidly obese, I tend to actually use sevoflurane. It's just that I switch off early. As soon as they actually, the surgeon, you have to watch the surgeon and see. As soon as the surgeon starts, closing, you actually stop the sevoflurane. And in the end, you just wait for the washout. It'll wash out. If the patient is breathing, they'll wash it out.
So ma'am also have asked whether any specific mention regarding the anesthetic agent of choice, which is safer.
You can use it with sevoflurane, isoflurane. You can use it with desflurane.
Right.
Halothane, it wasn't. I don't think I have any experience with it. I think it wasn't used with halothane, but I think with the all neuro agents, I think isoflurane, sevoflurane, desflurane, you can use with any of them. Rather, I think for desflurane, because it depletes the ozone, it's actually recommended that you use the minimal flow, even to metabolic rate. And it used to be costly, and still probably is costlier than sevoflurane. So
Right.
conserving that made sense, using a desflurane. Rather, saying that it was when desflurane was introduced that the circle system actually came into vogue. People started, oh, it is costly. Let's, we need to conserve this. And people started, because sevoflurane, people were still afraid. They used to think that if you use with soda lime, it is going to compound A, compound B, compound C, all those kind of things. Kidney injury, it got 7 fluoride atoms. So yeah. But the fluoride, the concentration need to be more than 50 parts per million with with sevoflurane, and that never reaches that.
Never reached, yeah. Yes.
And interestingly, people have seen that the amount of kind of kidney injuries which happen, it can happen with other agents as well.
Yes.
It's probably related to more to hypotension, intra-op hypotension, rather than the agent being used.
So Smitasha madam have asked whether we can use low flow anesthesia with supraglottic airway devices.
I've already answered that at the end of my lecture.
Yeah.
So I use it all the time. I mean, I do almost 80 to 90% of my cases with supraglottic devices, and I use low flow anesthesia for all of them. But like I said, I don't go to minimal flows. Okay. Like my rule is of 70. I use oxygen air, so 0.7 and 0.7. So I 5 to 0.7 and flows of 700 mLs. And so that is probably between your minimal and low flow anesthesia. And that's because over the period of time, I realized that when I'm in trainees and they, they want to use that kind of flows, if they reduce the FiO2 to around 50%, the dilution because of nitrogen actually goes down rapidly.
Correct.
So if the more the air you introduce along with the oxygen, because air has got nitrogen, isn't it? You are providing more nitrogen, and that is accumulating within the system.
Yes.
So if you keep the nitrogen levels, that is the air, to around 20 to 30%, then you're safe. Yeah. The lowest it goes is around probably 40%. And that, these are semi-closed system, that once the excess gases build up, they do vent out. And okay, a little bit of will go into the, the scavenging system.
Yes, yes.
But that's I think,
Sir, we do not have air facility for air here.
Yeah.
And plus we do not have BIS monitoring and AGM.
In all.
Yeah.
So
setup.
how do we go about with
You can't.
low flow?
like I said, unsafe.
Okay.
So can purely oxygen be
You do not
used?
actually have, well, saying that in spontaneous breathing patients. Okay.
Kindly mute, please. Yeah. Yes, sir.
So if you are actually doing with, with spontaneously breathing patients without neuromuscular blockade, you can probably still try that.
Okay.
Because then your patient becomes your monitor.
Mhm.
If the so you're worried about two things you're worried about here, right? One is the oxygen, right? So I've given you the trick for that. So trick for that is that you use the higher concentration of oxygen and keep that. The other thing is to actually then you have to have a close eye on the patient monitoring.
Somebody is still is mute.
Why did they unmuted themselves? Hello?
Yes, sir.
Yeah. Yes, sir.
So can we
Yeah.
start with
No,
only
but with
oxygen?
if you're using, sorry, if you are actually going to paralyze the patient ventricular tube, then I think it's not very safe
Okay.
to actually do it without actually having monitoring. And that's why the first part of the lecture is about, workstations and workstation means monitoring. Just having a machine which looks modern is not a workstation. Okay, that people need to be clear. It comes with all those aspects that it has got monitoring for gases, it's got monitoring of the airways. Okay, it's got proper monitoring or multi-para monitor. Okay, if somebody telling you I'm selling you a workstation, then they just are not giving this, then they're just selling you an anesthesia machine.
Yeah.
Right.
Yeah, sir. So what all should we look for when we are going to buy a machine then?
So like I said, the machine is the basic anesthesia machine, you all know. Okay, it's just that everything is there. So you need to make sure that it has got end-tidal monitoring for your oxygen. So inspiratory, expiratory oxygen, your CO2 capnography is there. Your end-tidal agent monitoring, ETAC monitoring is there. Okay, and that it allows you to have age adjust. So when you actually input age, it will actually automatically change the age of that. Okay. And then comes your multi-para monitor. So this should actually come as part of the workstation. When anybody is selling the workstation, they say, no, the workstation actually means that there is monitoring. Now, about the EEG monitoring and things, those are.
Okay. So there was one more.
EEG monitoring, those are just additional things.
Mhm.
Okay.
So can I ask one question?
Can I ask question?
Yes,
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 yes, sir.
please.
I'm Dr. Gore from Pune. Thanks very much for presentation. I just want to know what is the importance of monitoring end-tidal agent concentration, whether it keeps us safe as far as awareness of the patient is concerned during low flow anesthesia, whether we have to have a good monitoring of end-tidal agent concentration, which we have not discussed in our just now our discussion.
I have actually mentioned that.
Yes, we have a mention. But can we have quantitative?
Yes, I have mentioned in the, if you actually see that, the first thing I mentioned why this is important.
CO fluid
I showed it.
concentration.
I showed the
1.5.
AG guidelines.
Yes, patient is paralyzed.
Yes,
Hello.
so it need to be more than 0. Mac, and Mac should be age adjusted, right?
Yes,
And it should be more than 0.7.
Yes. But
I did mention.
in terms of not in terms of MAC, but in terms of direct agent concentration.
No,
like
it is Mac.
1.5.
No,
No,
listen.
it should be
No,
MAC
it has to
only.
be Mac. Yeah.
It should be MAC
Mac,
and not
absolutely.
1.5 or 2
No.
end-tidal concentration. No.
No.
Okay. Thanks very much.
If you actually, if you're on the group and if you go to my last post, this is from 2014.
Right.
actually I've shown
I'm
graphs.
not on the group. I'm a institution consultant.
Okay,
So
yeah.
can
But
I-
if you-
Thank you, sir.
anybody
Thank you
can
very
be.
much.
We have professor level people from all over the world
Yeah,
on the
yeah.
group, so anybody can actually be on the group.
Yes, sir. Yes, sir.
Yeah,
Thanks very much. Thank you
Yeah,
very much.
so there is actually graphs. It was actually published in BJA probably in I think it's 2008 or something like that. So they have actually given graphs.
Yes, yes.
So way which you can use. So I have posted those graphs on the group where you can. It's a very tedious process. See, it's not easy to actually know what the MAC is going to be for what age and what flows and those are. So I think that's what it makes. That's why I'm saying all those calculations become irrelevant. All those complex become irrelevant when you have good monitors.
Right. Thank you, sir. Thank you.
Sir, can I ask one question?
Yeah.
Yes.
Yeah. Sir, see, of the 4 requirements, we have soda lime, ETCO2, and dragger machines, Fabius Plus. But we don't have gas analyzers. So up to what liters we can practice safely? From at least 4 liters, can we come up to 2 liters?
No, I didn't get that. Sorry.
Mm,
What do you have? What you don't have?
we don't have gas analyzers.
Yes, analyze.
Yeah.
Yeah. And other things we have, suppose soda lime, ETCO2, and good machine workstation like Dragger Fabius Plus.
Yeah.
So we can't apply low flow anesthesia, but then up to 2 liters can we use?
Yes, you can. You can. I think, like I said, that's the thing with anesthesia. I mean, the monitoring makes you safer, allows you to actually do that. And I think everybody, I think it's now a national recommendation. I mean, the problem with Indian setup has been they don't. I mean, even with CO2 monitoring, they were so reluctant to actually bring it into the minimum standard monitoring. Now, these have actually moved on. Now, this is 2021 guidelines coming from AEGBI. And I think we need to move on. These are not costly monitors. Okay, these are not costly monitors at all. These are now the newer machine actually combine them. So they are actually part of it. So if you do not actually have the monitoring for that, so all you can do is try to actually maintain the MAC. So you can actually, like I said, look at the graph and keep the patient into around 0.8 to 1 MAC throughout and then you're safe. So you can actually go up to 1 liter. Yeah.
Namaste, sir. I am Dr. Leo speaking from Sangli. I have a small question. When you shift to low flow anesthesia, then do you need to increase the concentration?
No, like I said, you don't do
anesthetic gases.
You don't do the same two things at a time, right? So when you're actually reducing the flow, you keep the concentration dial constant. Okay.
Till the end, after some time, you have to increase or decrease.
Yes, but that is only possible if you actually have the monitoring, isn't it? If you actually have gas monitoring, then you can do it. Yeah. So yes, it requires actually, and one of the greatest advantage of nitrous oxide is that your requirement for sevoflurane goes down to almost like 0.2%. Yeah. Nitrous oxide is fantastic to use with low flow anesthesia and with volatiles. Your requirement, I think, you would be using minuscule amount of sevoflurane if you're using nitrous oxide. So air is all. I think
what the concentration?
Shosha. So we keep talking about oxygen air, but I think if there is no contraindication to using nitrous oxide is actually very economical. But one of the problems with nitrous oxide is hypoxia. Okay, it will accumulate. So after some times you will need to probably switch off.
Percentage.
Sorry.
So what should be the percentage of oxygen to nitrogen?
Hello?
Yes, sir.
Yes.
What should be the concentration of nitrogen to oxygen percentage wise in low flow?
It doesn't matter. It will accumulate. Whether you use 50%, you use 30%, it will accumulate. So the lesser of nitrous oxide you use, it will probably take longer to actually equilibrate and accumulate, but it will start accumulating.
Yes.
Yeah.
So even if you use 50-50, so even if you, I think with low flow anesthesia, 50-50 is fine. You're not looking at the thing. It will accumulate. You have to have the monitoring of oxygen. You will actually see that you can actually go to hypoxic levels very quickly if you do not keep an eye on your FI. That's the disadvantage. If you don't have these monitors, it becomes difficult. Yeah. So you can have all calculations. You can be the best mathematician. Still, I think it becomes a very tricky. I think that's the reason why people are reluctant to actually go on the low flows. And they say, okay, fine, what is there if there's some amount getting wasted in the atmosphere? Okay, but at least they are safe. They're not going to have a hypoxic patient because that will cause damage to the patient.
Yeah, definitely. Thank you very much, sir.
So there is a question. In short surgical procedures, daycare procedures, can low flow anesthesia should be practiced, or because it will take time for
No, it depends on the duration. So even if you say if you have an hour's case, then I would actually go for a low flow. But it's like 10-15 minutes, that you need that high flows for 5 to 15 minutes. Then there is no point in actually trying to, minimize that. Yeah, by the time you reach, then it's time to wake up the patient.
Yes.
So that's not, but if you even have 1 hour, so even if you do short cases like, the arthroscopies, I use low flows.
Yes.
So once the patient is there, then it can go on low flows. And the other advantage of low flows is that patients do wake up quicker as well.
Yes,
the washout is also quicker. Yeah.
Yes.
So from low flow going and so washout is quicker, patient wake up very quickly. Yeah. So you can, like I said, so it depends on duration you're expecting.
Yes.
Yeah. Any other questions?
Yes, I will just check.
Hello.
Yeah.
So there is a question from Dr. Khernar from Nasik. In cardiac, we need to disconnect the circuit when the surgeon demands lungs down.
Yes.
When reconnecting again, do we need to change the flow settings again?
Absolutely, because it's not because it's just not for a second. It is actually for a few minutes when they actually have disconnection, and then you are actually going back. You have to increase the flow. You can't actually keep on the low flows. Your patient will actually wake up.
Any more questions?
I don't know, but there are actually ways of, I think, when you disconnect, if you actually have some sort of system where you actually just seal it off for the time, then maybe you don't actually have to go that higher flows.
Yes. For the time being.
Yeah, gases are going in and the bag is going. Yeah.
Anyone wants to ask? Sir, we had almost 140 to 150 people attending here on Zoom, plus the YouTube channel live streaming is going on, sir.
On YouTube, advantage is they can actually start at any time and then continue. So whenever they start at the beginning. So whatever level you are, so they can actually watch as. Like I said, I tried to actually simplify, took away all the complex equation, which actually scares people. Try to keep it simple.
Yes, sir.
It's not like said. I think when people are actually buying the workstation, they make sure that at least these things are there within that monitoring, the gas monitoring, enteral CO2 monitoring. This should be essential part, and then you can actually practice any kind of anesthesia then. And the cost I think probably of these have come down significantly.
Yeah, we are getting this on rental, sir. We can just order the leads and the machine comes free.
Yeah,
so
that is the model for a lot of equipment where they say that they'll give you machine if you use X number of like these electrodes, or use X number of, say, even for say bear huggers. He say you use 100 bear huggers a year, take the machine free, keep it free for that time. They will obviously take it back if you don't use them.
Yes.
So that marketing is there. Like Desflurane, these guys would give you the vaporizer free as long as you use X number of bottles a year. So this has been there for, I mean, even UK follows, a lot of places follows that kind of system. BIS again is more important if you're using TIVA technique alone. So that was one of the, when you look at the NAP6, I think it was, which they looked at awareness, and in that they've seen that the incidence of awareness is minimal because everyone monitors, at least in UK, everybody monitors the MAC. So as long as the MAC remains between 0.7 and 0.6, patient asleep at 0.6, they don't remember anything.
Yeah.
But as long as you keep it more than 0.7, and that's what the AGBI guideline says, that is age adjusted. So problem will happen with if you don't actually change the age. So most monitors are actually set to age of around 40 years. And the younger patients can require, higher MAC. Whereas it's the opposite in the older patients. Older patients, for the same concentration, you can actually get much higher MAC in the elderly patients. So you can overdose the elderly patient with volatiles. So it's only for younger patients where you want to actually keep the concentration on the higher side. Patients who are abusing drugs, patients who are alcoholic, they tend to require slightly higher MAC.
It's similar to when we started using ETCO2, we realized we are over-ventilating the patient.
Yeah, exactly. Absolutely.
Yes.
Same thing. And if you start using BIS monitor, you will realize that even with 0.7 MAC, you actually are in the deep stage of anesthesia, right? Yeah. And if you do that with blocks on that, you will find that your BIS is like around 30, 35. You can actually go down to 0.2 of sevoflurane and still, so they are asleep. So we are actually keeping them sleep well. Okay, so that's not a problem. But in certain cases, we can be overusing. And same thing with ventilation, yes. I mean, we want to be ventilate the lungs nicely. Squeeze, come on.
Yeah.
And we wash out CO2, so yes. And so when people are actually saying the CO2 is reducing, they're probably ventilating too hard.
So there is a question in the beginning whether a PEEP can be given. I mean, maybe they want to ask whether PEEP, timing of PEEP, we should give initially only, or
Yeah, always from the very beginning. So if you want to prevent, especially, so you need to understand that if you look at the physiology, okay,
Yeah.
so anyone at age of 45, the
Atelic.
closing capacity exceeds the functional residual capacity and the lungs
Right.
will start collapsing. So if you're actually having a patient who's going to lie flat and he's more than 40 years, start giving PPAP from the very beginning.
Yes, right.
60 years, above 60 years, they start having collapse
Autopsy.
even in the sitting position.
Hmm.
Okay, so always either have them sitting up, induction always at slightly sitting up. It not only helps in maintaining the functional residual capacity, but also prevents aspiration as well. So, don't need to actually have patient completely flat. Yeah, sit them up a bit and apply PEEP from the very beginning. And even with like spontaneous ventilation, you can actually have the APL valve to 5 to 10 centimeters. I can show you where I actually have videos where
Yes, sir.
you can actually keep the PEEP to around 70 and still patient will be breathing fine. No
Right,
leaks,
sir.
nothing.
Yes.
Yeah.
Any question?
Any more questions?
No, looks like we cleared all doubts.
Yes, sir.
So
And
at
you can
least-
always, like I said, you can always ask question on the group anytime.
Yes,
Yes,
sir.
Yeah.
Thank you so much, sir. Thank you so much
You're most
for
welcome.
such a wonderful and giving us your valuable time.
Yes.
And we had almost 150 participants at one time. And I hope now we can, because of the corona and COVID conditions, people have slowly switched over from the main circuit to the open circuit, and we have put our foot down even in the smallest setups for workstations.
Yeah.
So now the hospital owners are asking us whether, what kind of workstation.
Yeah.
So this was a lecture to open up the concept.
Yeah.
And so we should know what we want from our machines,
Yeah.
so that the
So, I
safe
mean,
anesthesia without awareness.
Yeah.
You know.
The machines are becoming, like I said, very complex. Okay. And to me, I think I want to have a robust machine, but I don't mind actually having a lower end machine but I want good monitoring. That is my take on it.
Yeah.
So I don't want a hi-fi machine, anesthesia part of it. As long as it allows me to actually deliver flows less than 1 liter, that's fine with me. Okay. And able to, but I should be able to monitor the oxygen, able to measure carbon dioxide, able to measure the end-tidal CO2 and end-tidal anesthetic agents. Those are more important to me.
Okay.
Yeah.
Yes.
So
Sir,
those
can
monitors-
machines be upgraded to this without
yeah, why
changing
not? Why
to,
not?
yeah.
I mean, yeah, there are monitoring
Modules to be attached,
modules,
yeah.
yeah. And more complex ones now actually also have airway pressure monitors, flow volume loops, those things. And
Most of the machines come with this now.
Yeah, ventilators are actually a lot more sophisticated. They allow you almost like the IT ventilator kind of settings. So if you got patients who's actually asthmatic COPD, then you can give pressure control ventilation. You can do that. So I think these are, I think, essential things. I think cost it doesn't mean that just because the machine is costly, that's going to be good.
Yeah.
Yes.
Yeah. So you need to be able to integrate the guys who are actually saying, he said, fine, I don't want your fancy display monitors and things like that. Give me machines which actually are robust, service is good, but I want these monitors should be part of the machine.
Okay. Yes. Maharish, any more questions?
No, ma'am.
Yeah. Thank you so much, sir. Should we
Most
conclude?
welcome, and it was a pleasure. It was a pleasure actually interacting with all
No,
of
this
you.
was our
pleasure, sir.
first CME, sir, of this year. So you have inaugurated. Hopefully, we have many more. We are planning twice in a month. And yeah, thank you, sir. So academics, beginning of academics for our branch. And on behalf of ISA Kalyan, sir, I thank you so much on behalf of all the delegates also. We have had delegates from all over Maharashtra and in fact all over India to join you, sir.
Thank you. Thank you very much. Thank you.
Yes. Shah madam, do you want to conclude?
Thank you very much.
Yeah.
Thank you, sir. Thank you very much.
Thank you, sir. Yeah. Shall I end the meeting?
Yes.
Yeah, we can. Thank you.
Okay. Thank you so much. Sir.
Thank you.
Okay,
Yeah.
bye. Bye.
Good.
Bye. Bless you all. Maybe you will stay for a minute or so before we disappear. Then.
Yes. It was a
Indian style,
pleasure,
stop
sir.
the job.
Yes,
Don't go.
Thanks.
Okay, see you. Bye.
Yeah.